Welcome to the weekly Neurology Deep Dive.
Glad to be here.
Today we're digging into a recent study on brain magnetic resonance imaging findings in anti N-methyl-D aspartate receptor encephalitis, or anti NMDA receptor encephalitis, as it's often called.
A really important topic in neuroimmunology.
Absolutely. And just a reminder for everyone listening, this information is purely for educational purposes.
That's right. It's a summary based on research by Khatib and colleagues published in Neurology, Neuroimmunology, Neuroinflammation in 2025.
For the full picture, you really do need to read the original paper. This deep dive has no commercial goals.
Our aim is simply to pull out the practical information that might be useful for your daily clinical neurology work.
Exactly. The study itself looked at data from 255 patients diagnosed with anti NMDA receptor encephalitis.
And importantly, these patients all had at least 1 year of follow-up data and critically available brain magnetic resonance imaging results.
So what were the main findings regarding those scans? What did they show overall?
Well, overall, about a third, specifically 31% of these 255 patients actually showed inflammatory lesions on their brain magnetic resonance imaging.
Okay, nearly 1 in 3. Were these lesions concentrated in particular areas?
Yes, they look at that. So limbic hyperintensities, those bright spots suggesting inflammation in areas like the hippocampus, amygdala, key for memory and emotion.
The classic areas we often associate with this condition.
Precisely. Those were present in 15% of the patients. That's 37 individuals out of the 255.
And what about lesions outside the limbic system?
Right, the extralimbic lesions. Those were found in a similar proportion, actually 16% of patients, which works out to 41 people.
So roughly similar numbers for limbic and extralimbic involvement overall. Did these extralimbic lesions have a particular appearance?
They did, and this is quite interesting. The researchers were able to identify three distinct patterns among those 41 patients with extralimbic lesions.
Okay, what was the first pattern?
The first one they described looked like multiple sclerosis lesions. This was seen in about 34% of those with extralimbic lesions, so 14 of the 41.
And what defined that pattern? How do they look?
They were described as small, well-defined oval lesions, typically found in paraventricular spots, infratentorial, or juxtacortical regions, visually quite similar to what you might see in multiple sclerosis.
So a pattern that could potentially mimic multiple sclerosis on imaging then.
Exactly. It adds to the differential diagnosis considerations. Then the second pattern, this was seen in 12%, just 5 of the 41 patients with extralimbic lesions,
What?
was characterized by extensive fluid-attenuated inversion recovery lesions. These were described as confluent, sort of merging together, involving at least 2 cerebral lobes.
That sounds much more widespread.
Yes, and sometimes these also involve the basal ganglia, cerebellum, or brainstem, so suggesting a more significant inflammatory burden, perhaps.
And the third pattern?
The third pattern was actually the most common of the extralimbic types. It was found in 54% of that group, so 22 out of 41 people.
Over half of them.
Right, and these were described as poorly demarcated, kind of fluffy lesions, patchy areas.
Fluffy, so less distinct borders.
Correct. They saw these in the cerebral cortex in 6 patients, the cerebellum in another 6, or multifocally in multiple spots in 10 patients, perhaps representing a more diffuse inflammatory response.
Interesting how varied these appearances can be. Did having these extralimbic lesions, and specifically these patterns, correlate with anything else clinically? Like, did they also have limbic lesions or different symptoms?
Good question. Yes, they did look at that. Almost half, 46%, or 19 of the 41 patients with extralimbic lesions also had the limbic lesions we talked about earlier.
So quite a bit of overlap there.
There was, and interestingly, within that group, with both limbic and extralimbic lesions, the fluffy pattern was the most common extralimbic type seen. It was present in 58% of them, 11 out of those 19 patients.
Okay, and what about symptoms? Did extralimbic lesions link to specific symptoms?
They did. Extralimbic lesions overall were associated with what the study termed non-typical symptoms of anti NMDA receptor encephalitis. In 56% of those patients, 23 out of 41.
Non-typical symptoms like?
Primarily cerebellar ataxia problems with coordination that affected 42% or 17 patients, and also motor impairment seen in 29% or 12 patients.
So the presence of these lesions outside the limbic system might point toward these less common motor or cerebellar features. That's useful clinically.
It helps broaden the clinical picture we look for. The study also mentioned something else important. overlapping demyelinating syndromes.
Right, I saw that. What did they find there?
So a small percentage of the total group 4%, which was 10 patients, actually had a coexisting diagnosis. 4 had multiple sclerosis, 4 had myelin oligodendrocyte glycoprotein-associated disorder, or MOGAD, and 2 had neuromyelitis optica spectrum disorder, NMOSD.
And did their magnetic resonance imaging patterns fit with this?
Very much so. These 10 patients primarily showed either the multiple sclerosis-like lesions, that was 7 of the 10, or the extensive lesions in the other 3.
And notably,
Notably, none of these 10 patients with overlapping demyelinating syndromes had the fluffy lesion pattern.
okay, that's a potentially important differentiator, isn't it?
Okay.
If you see fluffy lesions, maybe less likely to be one of these overlaps.
It seems that way based on this cohort. Now, perhaps the most critical question is about outcomes. Did these different lesion patterns affect patient recovery?
Yes. What did the data show regarding long-term recovery?
This is a key takeaway. The study found that patients with either the multiple sclerosis-like pattern or the extensive lesion pattern had lower rates of good recovery.
And how did they define good recovery?
They used a modified Rankin scale score of less than or equal to 1, indicating no significant disability measured at 2 years post-onset.
Okay, so what were the recovery rates for those groups?
For those with the multiple sclerosis-like lesions, only 42% achieved that good recovery mark. That's 5 out of 12 patients evaluated at 2 years.
Less than half.
Yes. And for the group with extensive lesions, keeping in mind it was a small group, the recovery rate was even lower, just 25%, only 1 out of 4 patients.
Wow. And how does that compare to patients without any extralimbic lesions?
It's a stark contrast. Among patients without extralimbic lesions, the recovery rate at 2 years was much higher. At 77%, that was 124 out of 162 patients.
77% versus 42 or 25%. That's a big difference.
It really is. And importantly, they performed a multivariable analysis to adjust for other factors.
And what did that show?
It showed that the presence of multiple sclerosis-like lesions was independently associated with a significantly lower chance of achieving that good recovery score at 2 years. The adjusted odds ratio was quite low, 0.1.
Meaning a much lower odds of recovery if you have that MS-like pattern.
Correct. And the p-value was 0.002, suggesting this wasn't just a chance finding. They couldn't include the extensive lesions in this specific analysis because the number of patients, just 4, was too small.
Understood. But the signal for the MS-like lesions seems robust. What about the fluffy lesions in recovery?
Interestingly, patients with the fluffy lesions had a recovery rate of 68%. That's 13 out of 19 patients.
Which is closer to the group with no extralimbic lesions.
Exactly. It was statistically similar to the 77% recovery rate seen in those without any extralimbic lesions. So even though fluffy lesions were associated with those non-typical symptoms like ataxia,
They didn't seem to predict a worse long-term functional outcome in the same way the MS-like lesions did.
that seems to be the implication from this data. Neither the fluffy lesions nor standard hippocampal lesions were independently linked to lower recovery in the multivariable analysis.
So bringing this all together, what are the main practical points for neurologists listening to this? What should we take away for our practice?
I think the key takeaway is that careful review of brain magnetic resonance imaging in anti NMDA receptor encephalitis matters beyond just confirming inflammation. Identifying these specific extralimbic patterns could be quite useful.
Useful in what way?
Well, particularly identifying the multiple sclerosis-like and the extensive lesions might signal a need for closer monitoring. It could potentially help prognosticate regarding long-term recovery.
Especially that association between the multiple sclerosis-like lesions and a lower chance of good recovery at 2 years? That seems quite significant.
It is, and for patients who do show those multiple sclerosis-like or extensive patterns, the study suggests closer clinical and radiologic follow-up might be warranted.
Why specifically?
Because of that association we discussed with overlapping demyelinating disorders like multiple sclerosis, MOGAD, or NMOSD, these conditions might require different or additional treatment strategies beyond standard anti NMDA receptor encephalitis therapy.
Things like intravenous immunoglobulin, IVIG, or other specific immunosuppressants, perhaps.
Potentially, yes, tailored more towards those demyelinating conditions if confirmed. So recognizing the imaging pattern could be an early clue.
These are definitely valuable insights for managing these often complex cases.
I agree. And it's worth repeating, this is a summary of one specific study. All the detailed methodology, patient characteristics, specific treatments used, that's all in the original paper by Khatib and colleagues.
Which everyone should consult for the full context.
Absolutely. And of course, we need more research. Larger studies, perhaps across multiple centers, would be really valuable to confirm these patterns and their implications.
Definitely. So as you finish listening, perhaps consider how identifying these specific magnetic resonance imaging patterns, the multiple sclerosis like the extensive, the fluffy, might influence how you approach diagnosis, how you monitor your patients, and even how you discuss prognosis with them and their families.
What further questions does this raise for you in your own clinical practice? It's certainly food for thought.
Indeed it is. That brings us to the end of this weekly neurology deep dive. Thank you for joining us.